ovarian cancer, and we're delighted to have Dr. John Coulter here to speak with us today. He's a great supporter of what we're doing in Ovacare and always gives of his time so generously in events like this. He's the practicing gynae-oncologist at the South Infirmary Victoria University Hospital in Cork. Is it me, or are the names of the hospitals getting longer and longer and longer? He's a UCC graduate since 1989, and he trained both in Cork and again one of these the Coombe Women's and Infants University Hospital in Dublin. And then he travelled to Australia to complete his fellowship training scheme in gynecological oncology. He's a member of the National Cancer Control Programme Guideline Committee on Hereditary Gynecological Cancers, and we're delighted to have John here to speak to us today. So without further ado, I'll call on John to say a word.
Thank you, Brian. Firstly, looking at your teal pinky, I'm delighted to have my pink shirt on, so we're both very comfortable in what we're wearing. Matt Hewitt is here this afternoon, a fellow gynae-oncologist here in Cork, and many of you might know Matt from speaking last year on ovarian cancer screening. Interestingly, Wednesday week is World Ovarian Cancer Day, and that's both myself and Matt's operating day. So on that day, it is very likely that we will be in the operating theatre operating on women with ovarian cancers. How poignant is that? If you think of a surgeon, what is a surgeon? The definition of a surgeon is somebody who is a physician who often operates as part of his or her practice. Very often at medical meetings, when we get up and give talks about ovarian cancer, we talk about the published trials, what research we're doing, and you're really the alpha male standing here trying to tell everybody else how great you are and how great your research is and what you're doing is. But today is completely different. This is a great opportunity for us to be able to talk about what we do and why we do it and why we make the decisions we do. Not all about how great the research trials are and the surgical trials are, etc. And when I was listening to Marianne and to Ruth earlier, sitting there, we're at one side of the desk when we're meeting all of our patients and their families. We have some idea, probably a very good idea, of what's going on the other side of the desk. We know the privileged position we're in because it is literally people saying to you, look, our lives are in your hands, you tell us what you need to do and why. But listening to the stories this morning gives us a great understanding all the time, which is very important to us, as to how exactly things are happening outside of the door. And that's why it's so important that the likes of Eileen Kennedy and now Vicky Cleary are working with us to be able to take that step further and be more available than we can possibly ever be to look after all of the issues that occur. So it is very heartwarming to us to listen to what you have to say, and that's one of the reasons why I came to Ovacare last year, knowing that it was on, because it was a day for patients and their families. And when I was training in Melbourne, there were many of those, and they were probably the best days, better than any meetings we ever went to. So thank you for your attendance. When we talk about ovarian cancer, let me just say a few things about what it is and how it spreads, because that's central to our decisions when looking after women with ovarian cancer and making our decisions. The ovary, when you're a little baby in the womb, grows down from high up on the back, down along the back into the pelvis, where it sits and joins onto the uterus. And it brings a lining with it. If you consider the inside of your cheeks and our saliva on the inside of our cheeks, that's kind of like the inside of your tummy. Okay, there's a lubrication there, there's a lining on the inside, and if you imagined that something was moving along that lining and bringing a little bit of the lining with it, and then ending up somewhere in your mouth or somewhere in your pelvis, you develop some bit of understanding of how ovarian cancer starts and spreads, because it's that lining, we think, that becomes malignant. So whether it starts in the ovary and spreads around the tummy, and if you consider the saliva in your mouth, we have fluid in our peritoneal cavity, or in our tummy as well, that's constantly moving upwards towards the diaphragm, and then going into special vessels, going into one of the veins in your neck, and back into the bloodstream. So you've got this washing type system going on. And ovarian cancer cells, number one, spread in that fluid, which is how they come to be everywhere in your tummy? Or number two, is it that that lining that has gone malignant on the ovary has also become malignant somewhere else in your tummy? Because that lining is the problem. So that gives you some sort of indication as to what our understanding is of what happens. And if you look at the diagrams on the right hand side as you're looking, you can see that ovarian cancer, that is stage 3 and stage 4, has spread around the tummy, very often in the loops of the bowel, very often up around the liver, on the undersurface of the diaphragm. And unfortunately, as Sharon had mentioned earlier, about 70 to 80% of women who are diagnosed firstly with ovarian cancer have got something that has spread to that level. And of course the symptoms, she also mentioned, are so vague for many months and even up to a year. 99% of women going to GPs with those symptoms will not have ovarian cancer. They'll have something else going on. So they can be very vague symptoms, and that's why the diagnosis can be quite late. And when we're operating on ovarian cancer, I'll sometimes use the phrase that when we open up the patient's abdomen, that it's as if somebody poured porridge or glue into your tummy, and it has spread along the surfaces. Ovarian cancer doesn't tend to invade so much into the bowel or into the bladder, but along the surface of it. And some of our problems surgically is that to try to get that off, if you're trying to get glue off something, you have to take everything out. You can't just peel it off very often. And as I said, the bowel, liver and bladder are organs that can cause us difficulty with surgery. So let's take a patient who's referred to me with something like this on a scan. This here is a cyst in the pelvis. This is a CT scan. That to us looks pretty benign. It's probably fluid filled, about 7-8 centimeters. So why is that patient referred to me? Even though the scan may say we're not really sure, but there's no other evidence of any disease elsewhere, so it may not be ovarian cancer. But very often the radiologist will say, not sure, consider referral to a gynecologist. And the reason that many of these women, even if it is benign, are referred to us is because there's always a small chance that it may not be benign. And if you're having surgery by somebody who's not sure whether it's benign or not, and they open it up and they find, uh-oh, there's more to this than on the scan, and I think this is malignant, they're probably faced with closing the patient up again and referring them to us for definitive surgery, and that's a second operation. So very often women will be referred to us not knowing whether it's benign or malignant, so that at least if we do the operation, if we do find something malignant during the operation, I suppose we are the people who are best placed to manage it there and then. Which goes a long way to the discussions we have. That happens sometimes. Very often it's benign on scan, and people will ring us and say, look, I've got a woman with a 7 or 8 centimetre cyst, it looks very benign on scan, is it okay for me to do the operation? And we'll kind of go, yes, it is, of course, because we can't operate on everybody. So, and on rare occasions they'll find, uh-oh, it looked benign on scan, the lab report comes back and it's not benign, okay, now you need to go to see John Coulter or Matt Hewitt or whatever. Okay, but that's not common. Usually there's a good indication on the scan that there's something amiss. So if somebody comes to me with a scan showing a cyst, my question looking at the scan is, do I think this is benign, or do I think that there's a high chance that this might be malignant? If I think it's benign, I'll very often say to the referring gynecologist, if it is a gynecologist, I'm happy for you to operate on this woman on your list. Okay? But what if I see a scan like this? Somebody from somewhere else sends me up a scan and said, look, I'm sending this woman to you next Monday, here's her CT, what do you think? And I look at this CT and I say, well, that now looks very irregular, it's solid and it's cystic, and this looks very different to this very regular type 1. And I'll also look and I'll say, uh-oh, high up in the abdomen, you've got this solidy kind of stuff here, which is probably tumour in the omentum, which is a layer of fat that hangs off the bowel. And I'll look at this scan and I'll say, uh-oh, this looks malignant to me. And that's probably the top of the cyst there as you slice up through the tummy. So I know even before this woman comes in, it's very likely that this woman is going to have probably an ovarian cancer even before I meet her, looking at the scans. And this is often the way it happens. We get the scans, we know before the woman walks into the room. So the first thing I'll often say to a woman when she comes in is, what's your understanding of what's going on? Or what's your understanding of why you're seeing me? Because some people might have looked up the internet or talked to friends or a GP and say, who's John Coulter? Oh, he's a gynae cancer guy. He's a what? You know, or we'd assume that women have been referred to us with an abnormal CT and that they've been told already that whoever's referring them is suspicious that there's something odd going on, and that won't necessarily have been the case. And that's a line I learned from one of the guys I worked with in Perth, which I thought was a fantastic opening line, because it gives us an idea immediately of what somebody knows or what they don't know. And the last thing you want to do is to start talking about this possible malignancy inside in the tummy, and this is all first-hand news and shock and horror to anybody. So this woman, for example, is sitting in front of me. I'll get an idea of where we're all at and whether we're on the same playing field or not. Then it's time for me to assess what are her symptoms like, because that's very important in deciding what type of surgery or whether surgery is going to happen. Because if she's got something on scan and I think, not sure really surgery is warranted just yet, but she's very symptomatic, then we've got to do something about her pain, and that may involve surgery. It'll give me an opportunity to examine the woman to see what can I feel abnormally. A scan is brilliant and it's probably better than me examining her, but I can tell a lot by examining the tummy, the lymph gland areas, and the pelvic examination. It tells me a lot about what's going on tumour-wise inside in the pelvis. It'll give me an opportunity to see what are the expectations of this woman and her family. In other words, may have been told by their GP or by a referring gynecologist, you will be having surgery for this, and X, Y, Z, and I might be changing opinion. I might be changing tack and say, well, hang on a minute now, let's discuss this. We may need to start with chemotherapy first for a number of reasons, and I'll get on to how we make those decisions. So I've got to know what the woman and family's expectations are, and then put that all together and decide on treatment options with them. I'll usually outline the goal of our treatment. If I'm pretty sure that this is an ovarian cancer in the scan, I'll very often not come straight out with it, but I'll say, I'm a bit suspicious that there may be something odd going on in your tummy. And I'll explain why. So that when I decide, or when we decide what the best treatment is, we've got to be able to talk about where surgery fits in and where chemotherapy fits in, and whether we're going to put the cart before the horse or the horse before the cart. And it's also an opportunity to encourage questions from the family and the patient, of course, at which time we'll often say, be careful of what you read on the internet. Because as always, and we hear it so many times, and I would probably do the same, you go off and you look at all the different websites, and of course all the horror stories there, and all what happens to stage 3 and stage 4, etc., and it just puts fear into people's minds. And we often say, look, ask us your questions and we'll answer them as best we can, rather than what you look at the internet may not apply to you at all. So it gives us that opportunity. So let's say, for example, that woman with the CT scan that has got that obvious probable malignant mass in the pelvis, tumour on the omentum, etc. And when we're operating on ovarian cancer, we know that there are two modalities to our treatment. Surgery alone, except in very rare circumstances, is not curative or is not the whole picture. It usually needs to be complemented by chemotherapy. Our aim of surgery is to try to get rid of as much of it as we can safely. In other words, to debulk the tumour, take the bulk out of the tumour. Because if you look at certain laws of biology and oncology, the less tumour nodule size you have, the better the chance that you won't have cells in the middle that are resistant to chemotherapy. In low oxygen levels, as were mentioned, the better the chance that they'll respond to treatment. And there are lots of studies out there, even going back to the 70s, to show that the women's best chance of getting a cure or an excellent control of this is being operated on by gynecological cancer surgeons that are trained to do it, who can try to minimize the amount of tumour that's left at the end of the procedure. And that's our aim. Sometimes we manage to get it all out. Often we don't, because there are so many what I call spots and dots around the place. You could be there for 24, 36 hours trying to get out every little spot and dot. And very often the phrase I will use is that we have to leave some of those behind for chemotherapy, hopefully, to work on. Okay? But there's no doubt, and it's well recognised, and I'm not going to throw up loads of scientific data in this presentation because this is a discussion to be understood by all of us. So the less we leave behind, the better the outcome. Could it be that the tumours that are easier to get out surgically are the less aggressive ones anyway? And they're the ones that are always going to do better. The more aggressive the tumour, the more it clings on to the organs it's stuck onto, and the harder it is for us to get out at surgery. That could be also at play as well. So when I'm looking at the CT scan and speaking to the woman and her family and examining her, I have to make a decision at that stage. Are we going straight for surgery to try to take as much of this out, or are there other things going on that make me wonder, should we start with chemotherapy first and then consider surgery afterwards? Things like, if I examine someone and look at the scan and I think that all of the bowel is wrapped up in this, and the chance of me needing to bring out a stoma is very high. And what if this woman has some arthritis? And I think she won't be able to manage this stoma with her arthritis. Or what if somebody has severe cardiac disease and I'm thinking of putting her through a 3 or 4 hour operation? Will she be able to tolerate that? Will the anaesthetist let us do it? You know? What if the lungs, the lining of the lungs have been filled up with fluid that are caused by the cancer cells? We know that that could cause very significant perioperative morbidity. In other words, that woman's ability to be able to breathe properly during the surgery and after the surgery severely compromised. Are we better off starting with chemotherapy first to try to shrink these areas down to make the surgery less morbid later on? And these are things going through our minds as we're seeing every patient in the outpatients, especially with a new proposed probable diagnosis of ovarian cancer. I mean, as surgeons, we're trained to operate. People who go into surgery, I suppose, go into surgery because they like doing surgery, you know, and it fulfills them. So for a surgeon to kind of say, no, I don't think an operation is the right thing just at the moment, is sometimes a hard thing to do, especially during an operation, when you make an incision all the way up and then find when you get in there, it is literally as if someone has poured glue in. The chance of me getting this all out without severe morbidity or even life-threatening hemorrhage to this woman is actually quite small. I think maybe I should stop and give chemotherapy a chance and then come back. And that's a hard decision to make intraoperatively because we know how much has been invested in our decision to operate. It's as if an operation, thank God, we're getting places. An operation, good. If it's doable, then that's good. And if it's not doable, what does that mean? Okay, so pre-op discussion about the surgical plan, and very often I will say just that. I will say, look, our aim is to take out the uterus, tubes, ovaries, any tumour tissue we can find that we can resect, and the omentum. Whether there's tumour in it or not, we're taking it anyway, because that's one of the little areas where these cells love to jump onto, and they could even be microscopically there. So usually we'll word people up before, and this is what we plan to do. But I'll often say, for that reason, especially if I'm suspicious on scan or examining the woman, that this might be a bit tougher than we think, and it may not be resectable as we think. I'll often say, look, there are times that we'll do the operation, we'll open you up, and we'll know during the surgery that this is potentially dangerous to you, and we might decide to stop for safety reasons to give you chemotherapy, so that after the operation, if I do end up saying that, it isn't hopefully such an awful shock in that things went wrong and I'm never going to be cured, or they're never going to get control over this, or this is so bad. At least if I say beforehand that there's a chance this might happen, and sometimes we do that and sometimes we put the cart before the horse, and at least if that's what does happen, you know, hopefully it isn't the end of the world, and that we've anticipated this may happen and we're used to dealing with that if it does happen. Okay, so we take out uterus, tubes, ovaries, the omentum, lymph nodes in certain situations, and other tumour nodules. The risk of bowel being operated on or a stoma is less than 3%. it's usually very low, and we try to minimize that risk if we can. And as I said, the aim is to remove as much tumour as we can safely. Okay? It's very important that we don't do something to compromise a woman's life by causing life-threatening hemorrhage just because we think we can operate on everything. We can't operate on everything safely. So we often make these decisions during the surgery. So, operation's over. It'll have gone one of a few ways. Hopefully, I'll be in a position to say it went great and we got out everything we wanted to. And that's, of course, what everyone wants to hear, and that's, of course, what we want to be able to say every time if we can, because we know how important it is to hear something like this. Or sometimes there may be a few spots in underneath the liver, you know, that are hard to resect, or there are areas right up underneath the heart, etc., that are hard to resect. And sometimes we do need to leave these spots and dots behind for chemotherapy, hopefully, to work on. And that's the way I'll put that. Sometimes, as I said, if things don't go well during the surgery and we've got to curtail what we do for safety reasons, it may be a matter of discussing, look, unfortunately, I didn't get to do exactly what I wanted to do because there was a risk of X, Y, or Z. So we decided to hold off for the moment. We'll give you chemotherapy, and hopefully, if that works well, we'll come back and go at this another day and hopefully have a better chance of getting it out then. So that's usually one of the three post-operative types of discussion. So what 3 means there is what I discussed, that we make a decision surgically that we may need for safety reasons to hopefully allow chemotherapy to do a good job for us, shrink things down and have a better chance at future surgery. Of course, this is not what anybody wants to hear. And as I said, as a surgeon, as someone who enjoys operating, as it were, it's a hard thing to do, to stop. But, as I mentioned, a physician who sometimes operates, we've got to think with our heads as well. Operate on what we should, not everything that we can, and that's important. And that's kind of how we think when approaching these. Some of the rarer types of situation can be the unsuspected cancer in a young woman. And the reason I say the difference is because very often in somebody who may be postmenopausal or to whom fertility is not important anymore, late 40s, early 50s, might be still peri or premenopausal, very often the preoperative discussion will have been, look, even if it's benign, I'll probably take out the uterus, tubes, ovaries and omentum anyway, because there's always a tiny chance that the lab might find a little bit of cancer inside in what we think is a benign cyst. So very often that is not such an issue for a woman in that age group who has finished her family. But however, for the younger woman, especially if we think it's benign and we find intraoperatively, I don't like the look of this, we have a few options. Number one, we can send her to the lab straight away while she's asleep during the surgery and ask them to do what we call a frozen section. In other words, to look at it under the microscope immediately while she's asleep. But the lab find it hard, and it's not fair in pathologists. Sometimes it can be very difficult to give an accurate answer with that type of section, rather than having the few days of the tissue being fixed and proper stains and all that kind of stuff. So that may not be an issue sometimes. So what we tend to do in younger women is that even if we think it may be malignant, would be still to be conservative. Just take out that ovarian mass, send it to the lab. We can always come back later and take more out if we need to, but we can't put stuff back in. Now, if there's an obvious cancer that has spread and we can see it and it's around the tummy, then we usually will have worded up the young woman at that stage to say, look, we are a bit suspicious. If we're right during the surgery, we are better off doing X, Y, or Z. But usually we tend to be very conservative in young women for fertility reasons. And as I said, once we get the correct diagnosis, we can always come back and do more if we need to. The worst thing in the world would be to take everything out and then the lab say, well, actually, I know you thought it was malignant, but guess what? It isn't. We can't do that. We can't have that. So if we decide for a number of reasons that I mentioned, either for medical reasons or for surgical reasons, that we're going to start with chemotherapy first, we have to get a diagnosis. We can't just assume this is ovarian cancer on scan and start chemotherapy for ovarian cancer, because number one, we might be wrong. It mightn't be cancer. It might be a bowel disease like Crohn's disease or something that looks like an ovarian cancer on scan, Or number 2, it may be a cancer, but it might be a bowel cancer that has spread to the ovary, or a stomach cancer, or a breast cancer that has spread to the ovary. We need to get the diagnosis, so we need to get a biopsy to get it right. Then when we have the biopsy, we can make a diagnosis and we can actually go ahead and ask our medical oncology colleagues to see the patient and start treatment with the intention of hopefully shrinking things down and then doing an operation maybe after 3 or 4 cycles, or sometimes if the chemotherapy is going so well and it's so rapidly reducing in size, we might elect to keep going with 6 cycles and then consider surgery at the end. Because these women that we decide not to operate on initially may also have symptoms that they need us to manage while having chemotherapy, or even before they start chemotherapy. Like if they've got a big swollen tummy due to free fluid or ascites in the tummy, we can drain that. And sometimes we need to drain it 2 or 3 or 4 times until hopefully the chemotherapy kicks in after 2 cycles or so and dries that up. So we will still manage the symptoms, nausea, pain relief, correct nutrition, whatever is going on that has stopped us operating initially, we'll hope to try to correct. And then we time the surgery depending on how well the chemo is going, etc. And there are some recent trials showing that in selected cases there is no difference in survival whether you start with chemotherapy first in these women and then do surgery, or start with surgery first and then give chemotherapy. So that's kind of reassuring to us making our decisions. Sometimes we'll operate when and if it comes back. Sometimes. Often when ovarian comes back, it doesn't come back in just one spot. It comes back in a lot of places. And the aim of surgery when you're operating on a recurrent ovarian cancer is to try to get out every last single cell if you can. And there's very good evidence in the literature that that's the benefit of secondary surgery. It doesn't hugely improve survival rate if you go in and try to get some of it out and you can't get much of it out a second go. The best person to operate on for a recurrent ovarian cancer, if possible, is somebody where it's taken a number of years to come back, and it's come back in 1 or 2 little spots that you can get out easily with surgery. The longer you go out and it hasn't come back elsewhere, the better the chance that this is only where it is. And if you can remove that and follow on with chemotherapy, then you're doing good. And that's when we tend to operate on recurrent ovarian cancers, not that commonly. Surgery can help in the palliative situation. It's not common, but sometimes we will operate if someone's getting an impending bowel obstruction. Even if we know this woman has been on 3rd, 4th, 5th line chemotherapy. Okay? And the aim of surgery is not to control or cure the disease, but to relieve an awful symptom, like impending bowel obstruction, or putting in a stent to the bowel, or just bypassing the area of obstruction. You know, sometimes somebody will accept a stoma in the palliative situation because it's better than the awful pain and vomiting that they have. But now, of course, palliative care, symptom control, has become so good that very often you can control these symptoms with medications rather than having to go back into surgery. But sometimes we will perform surgery in the palliative situation. And as the saying goes, as the sun sets on my talk, just in conclusion, something I'll often say is we'll operate when we should, not because we can. Okay, which means as trained gynae oncologists, we went through a training program that just didn't teach us to do surgery. It taught us to think about what we're doing and how to make decisions. Where I was training in Melbourne, Australia, the team, we gave our own chemotherapy. And then a medical oncologist came on board while I was there. You know, we went over to the radiation oncology place across the park and sat in with their radiotherapy as well. So the people who were training me were kind of trying to train you as an oncologist rather than just as a surgeon. So it's important that we, as part of the multidisciplinary team, engage the brain and decide, you know, when to operate, and sometimes importantly, when not to operate, and give something else a chance first to be able to operate more safely in the future. And if we don't get to do what we want to during surgery, it's not always that's necessarily big trouble. We are forever seeing outstanding successes that we thought might never happen. You know, I've operated on women where I've just opened the tummy and went, you know, we're not going to get much joy here today. This is just, you know, very, very difficult. Give chemotherapy and come back and fantastic response to chemotherapy and get a great operation done. And years later, these women are still coming back to the clinic. Whereas day one, you look at what the initial surgery was like and you go, oh God, this is big trouble. We get some outstanding successes. So if it happens that things don't go exactly as we want to initially, that doesn't mean that it's not going to get better from then on in a number of women. So we've got to be careful of what we do, and as I said, operate when we should, not just always because we can. Thank you very much. Do you want to take some questions? I'm happy to take a few questions if anybody wants to ask anything. One thing I suppose I will mention, somebody might ask it, is the radicality of surgery. There's some data from other areas in Europe and in the States where they're doing what we call ultra-radical surgery. In other words, they're spending 8 or 10 hours. If I talked about the lining of the cheek inside in the tummy, stripping everything from everywhere in an attempt to improve survival. And they do show that survival may be improved by doing that, but one of the problems with that is the morbidity and the mortality rate associated with such ultra-radical surgery turns a lot of gynae-oncologists off the idea that you're going to lose X number of women during the surgery. Okay, so in case any of you were looking at something on the internet about ultra-radical surgery, etc., there's for and against that. But as I said, I'm happy if anyone's got any questions or if they want to wait for the panel, whatever suits.